Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation. I'm Dr. George Quigg, Senior Global Medical Education Manager for Brain and Neural Pathways, and it's a pleasure having you join us today. Our Neurotraining Academy should be your go-to platform for direct access to the latest educational content in neurodiagnostics, neurocritical care, and neurosurgery, all in one comprehensive location. So please visit our website frequently at neuro-training.academy. Our webinar is entitled EEG in Epilepsy, What Every Technologist and Neurologist Should Know, featuring Dr. Mark Quigg. Dr. Mark Quigg received his neurology training at the University of Virginia and neuroscience training at the Karolinska Institute in Stockholm, Sweden. He specializes in the evaluation and treatment of difficult to control seizures and the neurological aspects of sleep medicine. He is the medical director of the electroencephalography and intensive monitoring laboratories and is an expert in using these tools to evaluate epilepsy, sleep disorders, and disorders with similar symptoms. He is nationally recognized for his clinical practice and research. He also holds national offices, including on the Neurology Board and professional societies for neurology and epilepsy. Dr. Quigg enjoys living in Charlottesville and is an avid runner and cyclist. He is also a woodworker and has put significant sweat equity into his old house in downtown Charlottesville. He has 2 children with his wife, Lara.
Thank you, George. Okay, guys, we're going to go over some aspects of EEG. I've got my disclosures here. None of them pertain to any problems with this particular lecture. All right, so we're going to talk today about some basics of EEG, the things that aren't often delved into. And so maybe you can think of this lecture as a little bit painful, a little bit masochistic, but it's going to be good for you. You will walk out of here feeling better because now you're going to know stuff that you didn't before. So we're going to go over 3 things here. What is the source of the EEG? We're going to spend most of our time discussing. We got these squiggles on the page. How did they get there? We're going to mention something very briefly, but importantly, what's the sensitivity and specificity of the EEG for epilepsy? What's the basic limits of our tool here? And then what kind of EEG testing is appropriate for a particular clinical situation? All right, so the source of the EEG. So here's a question that you guys can answer, multiple choice. So what is the main neuronal source of the EEG? Is it action potentials of the presynaptic neurons, postsynaptic potentials of postsynaptic neurons, or is it dominion power?
52% for A, action potentials of the presynaptic neurons, and 50% for postsynaptic potentials of the postsynaptic neurons, and 5% dominion power.
Okay.
So A seems to be a winner by a slight margin.
Okay, so here we go. So what we're going to do is, if you remember that kids show, The Fantastic School Bus. So, you know, the teacher and their students shrink down and they travel in little places and then eventually return to real size again. So that's what we're going to do. We're going to take a little teeny magic school bus and we're going to start at the neuron. And we're going to work up from neuron through its connections to the anatomy of the nervous system. So here, this is kind of the outline of the first part of that magic school bus ride. So we're going to talk about the presynaptic neuron first. Okay. So there's something called the resting membrane potential. And I think if you just simplify this in terms of what a neuron actually is in terms of the EEG, it's just a battery. And it takes energy and it takes energy and pumps to keep that battery charged. And one of the aspects of this fancy battery is that the neuron has a leaky membrane, right? So if you just think of a big saran wrap bag, it has little pores in it, and the neuron's not much different. It has little pores that allow salt and other anions and cations to leak through from the inside and outside of that cell. And these pores are specially shaped to only allow particular positive or negative anions to flow in and out of the cell. And there is something called the ATP pump. In other words, it's again a motor essentially that selectively pumps salt, Na, sodium, cations out of the cell and pulls in potassium cations into the cell. And that pump, by pumping these cations on either side of the cell membrane, creates a charge because there's an unequal number of positive and negative charges now maintained by energy across that cell membrane. That standing battery charge is called the resting membrane potential, or EM. So you can see in that graph in the lower right-hand side that every neuron just kind of sits around with this negative charge that is awaiting to be manipulated. So this resting membrane potential is kind of the standard state. And if you fluctuate, if you go above that, if you turn that charge positive, that's called a depolarization. If you make that charge even more negative, that's called a hyperpolarization. So now we're going to go from the presynaptic neuron to the next part at the end, or at the body of that presynaptic neuron, right before the axon. The axon is the connector from one neuron to the next, and there we're going to see fluctuation of anions and cations. So what happens is, with the fluctuation of the charge in the neuron, you can trigger various other anion channels, and those are called voltage-dependent ion channels. You can kind of think of it as a loaded gun or a mousetrap ready to set off with the right conditions. So as the charge across that neuron fluctuates in a depolarization or a hyperpolarization fashion, there's a certain threshold potential which will trigger these voltage-dependent ion channels at a particular voltage to snap open. And what results is something called the action potential. Am I triggering nightmares from biology? So what happens is, once the neuron rises above a certain trigger level, the threshold potential, these pores abruptly open up because they are sensitive to voltage, and allow the sodium cations that are outside the cell to abruptly flow into the cell. And that causes an abrupt, big change in the charge of the neuron. And when it hits that peak at the top of this graph here, then a series of other voltage-triggered channels will open up and allow potassium to flow in to counter it. And what you have is an abrupt flick or fluctuation of charge in the neuron. And that triggers the action potential. Now, once that action potential is triggered, So we're in our presynaptic neuron, and here's a long axon. And this action potential now is a wave of charge, a spark, if you will. And that spark is traveling down our fuse here, and it's going to go to the synapse, which is where the presynaptic neuron and it's the next one in the chain, the postsynaptic neuron, essentially talk to each other. All right, so now we're at the point of the fuse traveling down the presynaptic neuron. So what happens is at the end of that fuse, or the synapse, there are a series of other of these pores, calcium channels that are voltage dependent. And when that spark travels down to the presynaptic synapse, it flicks open these calcium channels and allows calcium to abruptly flow into the cell. And when that happens, it causes a series of vesicles. Vesicles are basically little bags of neurotransmitter contained within the neuron, and allows them to travel to the membrane of the presynaptic neuron, fuse with that membrane, and release their contents into this transsynaptic space, the little lake, if you will, of fluid that separates the two neurons. When those neurotransmitters hit the next neuron in the chain, it triggers things called postsynaptic potentials. All right, so now we're at the postsynaptic neuron. We've had neurotransmitters cross this little C, separating the two neurons. And let's see what happens next. So there are two kinds of gates that are triggered by this neurotransmitter. So if you think of a neurotransmitter as a key and these postsynaptic channels as locks, the key will travel down, and a particular key will only trigger particular locks. So a particular neurotransmitter will only open or trigger these particular pores according to their configuration of the lock. And these pores can be, or channels can be divided into two basic types. The first are excitatory. And this just shows three different kinds of excitatory channels. The other main type is the inhibitory postsynaptic potential. And that's mediated by another series of neurotransmitters, mainly something called GABA. And the GABA receptor allows other cations and anions to flow again through these pores. Now, the nifty thing about the excitatory postsynaptic potential is that particular key and lock. When that pore opens, the change in the voltage of the subsequent neuron will flow up. It becomes depolarized. It is excitatory. And so the little fluctuation of voltage jumps up a little bit when that pore opens. An inhibitory neurotransmitter, on the other hand, the GABA one, when it hits its lock, that pore opens and a negatively charged chloride channel opens, goes into the postsynaptic neuron and causes a downwards deflection of the voltage, a hyperpolarization. So here's the upshot of these chains of pore changes and voltage fluctuations across the neuron. What we are actually measuring on the EEG are these little changes in both excitation and inhibition in this postsynaptic neuron. Okay, so you can kind of think of it as, again, a battery, and we're either charging or decharging that battery. But once you take millions and millions of neurons, all being charged or decharged simultaneously, it is that flow of charging and decharging, or excitatory and inhibitory postsynaptic potentials, that defines the voltage changes that we are able to measure when you are sticking electrodes on the skull. Okay, so that was the first part of our magic school bus journey, and this is the main point here, is that the EEG is the summation of all these excitatory and inhibitory postsynaptic potentials in the neurons in that second part of these neuronal chains. All right, now our magic school bus is going to take the next level of magnification. We're going to go a little bit with bigger structures now. We're going to look at how the anatomy of these neurons enables us to measure the charge, and how their location in the brain affects what we actually measure. All right, so let's go first to the neuron. So if the EEG is the sum of excitatory, postsynaptic, and inhibitory postsynaptic potentials, well, that wouldn't matter unless the neurons were actually organized for us to be able to actually measure it. So what do we mean by this organization? First of all, the neurons have to be oriented in a certain way for us to pick up an electrical dipole or an electrical difference. And the thousands and millions of neurons have to be organized into essentially little clubs to summate enough, to have enough neurons to make a difference so that we can actually measure them. So orientation. So the fact is, even though there's millions and millions of neurons that we are measuring their fluctuating potentials, it's only a small group of them that are oriented radially in the brain. And these are called pyramidal cells, in that because they are pointing like from deep in the brain towards the skull radially. And it's these radial neurons that enable something called separation of charge. So in other words, it's not enough just to have electrical charge. You have to have them oriented so that we can pick them up with our electrode array. So for example, if we have a bunch of neurons that are horizontally organized so that they're talking to each other pre and postsynaptically, all that will cancel out because the difference in our channels from time to time just zeroes out. If you can see, if we're measuring horizontally, the difference in channels equals up to 0. But if we are measuring vertically oriented neurons, now we're able to, example, this particular electrode here is going to have a different overall charge addressed to it than the one forming the second input of this differential amplifier. So the point being is that it's the small group of pyramidal neurons that we're actually measuring. Now, these pyramidal neurons are just not distributed helter-skelter throughout the brain. These things are oriented in what we call cortical columns. So if you just think of hundreds of thousands of these neurons that are oriented in particular layers. So all the cortex is organized into these 6 particular layers that define the connections that enable organized brain activity. So, you know, the brain itself contains 10 to the 9th or 100 billion neurons. There's 100 billion glial cells that protect and work with the neurons. These are arranged in 6 layers, and they are grouped within these functional cortical columns that basically define function. So here's the layers of neurons. You can see that the pyramidal cells are preferentially located in these layers 3 and 5. And these are the ones, again, because they're radially oriented, we can pick them up better on the scalp. The others are connected horizontally, and we don't necessarily pick them up. Now, these cortical columns work together to provide function. So, for example, in the visual layer of the cortex, back in the occipital region of the head, these cortical columns both work together and work as teams, if you will, to supply particular functions of vision, whether you've got a moving line from left to right or the color red. Each group of the cortical columns work with each other to define these functions. And they both inhibit and excite each other depending upon the function that is needed. Okay, so that's the cortical column. Now, the cortical columns are distributed throughout the brain in our next step. So now we're going to go to the actual cortex itself. Now, these cortical columns, again, aren't sufficient for us to pick up brain activity. We still have to have some sort of organizing function of the brain so that the waves of potentials are basically organized into rhythms that we can measure. And that is done through a series of connections that emanate first from the brain stem. There's something called the reticular activating system, which is important in regulating state, sleep versus wakefulness. So whether or not you are asleep or awake, this reticular activating system changes the pulse rate or the kind of standing rate of discharge of particular groups of neurons in a place called the thalamus. And there's 2 areas of the thalamus that are important, the reticular nucleus of the thalamus and the thalamic relay nuclei. But you can basically think of these guys as metronomes or timekeepers. And the rate and pattern of the metronome beating is changed by whether or not you're asleep or awake. And what these metronomes do is talk to the pyramidal neurons in the cortex. Those in turn are contacted within the cortical columns and feed activity back. So they report on their activity back to the thalamus. And now we've developed this thalamocortical loop. And the thalamocortical loop of activity is basically the an orchestra being conducted by the thalamus now is able to keep time and organize the cortical activity into measurable rhythms. Okay, so now we're at the level of the cortex that is now being organized into measurable rhythms. The next step then is to see how the placement within the cortex affects what we can measure on the skull. All right, so here is a question. What is an important effect of the skull on EEG signals? And here's the multiple choice. It acts like a high-pass filter to remove low-frequency signals. It acts like a high-pass filter to enhance high-frequency signals. It acts like a low-frequency filter to remove high-frequency signals, or it protects the brains from heavy-handed texts.
Okay, thank you. We'll launch the poll, and they can see again the choices. So it acts like a high-pass filter to selectively remove low-frequency signals. It acts like a high-pass filter to selectively enhance high-frequency signals. It acts like a low-frequency filter to selectively remove high-frequency signals, or it protects the brain from heavy-handed tests. 39% thinks it acts like a low-frequency filter to selectively remove high-frequency signals. Number 2 was A, it acts like a high-pass filter to remove low-frequency signals, and then 25% was choice B, and only 6% had picked choice D. So it was C, A, B. That were the choices, with the highest one being for C.
Okay. So it's a high pass filter in a way. So let's look. So because we are putting electrodes on the skull, which has skin and has to pass through the marrow of the scalp and the meninges and all the tissue that separates the electrode from the brain's surface, there are properties of the system that change what we can actually record. So one particular limitation is that the amplitude of the signal, just how big of the signal we can measure, is limited by the distance from the brain. And because the brain is a complex 3D structure, deep cortex may not be easily measured. Okay, so anytime there is an increase in distance between the cortex and scalp, that will decrease the amplitude of the signal. Remember that when the EEG is actually measuring the brain, we're assuming that the brain is basically a smooth northern hemisphere. And that's the mathematical model, but the actuality is because it's not a smooth structure. Finally, the filter effect is that the skull and skin acts pretty much like a high frequency filter. So it's removing all those little very high frequency activities that we can actually measure if we put electrodes directly on the cortex. So basically we can really reliably see frequencies or patterns that are in the high frequency band. The other aspect that limits the scalp EEG is that it takes a lot of cortex for us to see what's going on the scalp. So there's different ways that people have determined this. There's some modeling experiments that kind of took a mathematical model of the brain and cortex, and they calculated that it took about 6 square centimeters of cortex required to generate a scalp potential that is visible on the skull. 6 square centimeters translates roughly to a square inch. There's been some later studies using actual electrocorticography, implanted subdural electrodes in patients with epilepsy, that demonstrated that if you have a region of cortex that is 10 centimeters square, so one of those large greater than 8x8 grids that we used to use, that you can only, that the limitation is that if the spikes involve greater than that 10 square centimeters, we can see them pretty reliably. But if they are involve cortex that's smaller than that area, we're only going to see a teeny number of those. So it takes a surprising amount of brain to generate something that we can see on the scalp. Here's a good demonstration of this. This is a patient who has subdural electrodes lying on the surface of the brain. And in the middle there, where it says hip depth, that's a hippocampal depth electrode into the brain region of the hippocampus. And then there are scalp electrodes in the bitemporal regions simultaneously. And so what this is showing is where the arrows are, is that you can see a series of spikes being fired off one after another in the hippocampus, but because it's involving a small region of brain and not really reaching cortex, and it's deep within the brain, far away from scalp electrodes, the scalp electrodes are uninformative. They are not showing those deep spikes generated in the hippocampus. This is a patient who has a subarachnoid hemorrhage. This is now a scalp recording. And what we're seeing here is there is some faster activities you can see in the right parasagittal chain, FP2 down to O2 here, where the activities are a little bit darker, meaning that there's faster frequencies, and the amplitudes overall are higher than in the rest of the brain. And that corresponds to a region in which the patient has had a craniotomy. So in other words, this is a direct demonstration of that filtering effect. So if you remove a piece of skull, what you end up having is the ability to see those faster frequencies, those high frequencies that are otherwise being filtered from the skull. We mentioned earlier that increased distance between the electrode and the brain is a big factor in determining how high the amplitude is from scalp recording. So here is a patient who has a subdural hematoma that is involving the right side of the head. So you can see on the left side of the head, there's this kind of arrhythmic delta activity, and it's all high amplitude. But in the rest of the scalp, it's very low amplitude, and that's because the brain is being pushed by the subdural fluid away from the electrodes and is now lower in amplitude. Subdural fluid, or it can be scalp fluid, or in other words, scalp edema. Here's the same situation, basically, in that we can see higher amplitude activities on the relatively unaffected left side of the skull, and on the right side where there's kind of puffy skin because of right scalp edema from the trauma, that we're not seeing much activity at all. So again, it's being separated or pushed away from the brain. Okay, so our magic school bus ride is now over. We can all relax. All the basic biology is done with today. What I'm going to talk about now, in something totally different, is the sensitivity and specificity of the EEG for epilepsy. You can tell I'm kind of covering important things that are disparate because, again, these are things that I find that with beginning fellows or residents that isn't really talked about much. So let's review what a sharp wave and spike is, because that is the finding that is associated with epilepsy, the interictal epileptiform discharge. And a sharp wave and a spike is things that interrupt and stand out from ongoing activities, so it has to interrupt background activity. The sharp part, the pointy part that would hurt you if you sat upon it, Has to have a duration from 20 to 200 milliseconds, spike or sharp wave. It has to have a negative potential, and it's followed by an aftercoming slow wave of the same potential. And you should be able to map it to the scalp, or to the skull. It has to have a cerebral distribution. So that's the definition of an interictal epileptiform discharge. Spikes can be focal. They can be in multiple places independently in the brain, and they can be generalized on the brain. And they can occur singly or in trains or in big rhythmic runs, or they can consist of multiple points followed by that slow wave. Here's a classic example of a spike in mesial temporal lobe epilepsy. This is a temporal lobe pathology, and you can see the sharp waves occurring in the left anterior temporal region, in the bipolar montage here, and in the referential montage here. That's what they look like. Now here's a question about these spikes. If you have, what is the sensitivity, the true positive yield of a standard routine EEG for interictal epileptiform discharge in known epilepsy? So in other words, if you have 100 people who have definite epilepsy, how many of them will have the abnormalities, the spikes seen on a single EEG? So how sensitive is the EEG? So is it under 10, 10 to 20, 20 to 50, or 80% of those 100 patients with epilepsy will show spikes on that single recording?
40% of our audience thinks it's 20 to 50%. 16% for choice A, 28% for choice B, 40% for choice C, 19 for choice D, which was 80%, and no one picked the EEG is highly sensitive, so it needs a hug now.
Yeah, so the answer is 20 to 50%. Kind of a big range, but we'll see why. So first off, okay, this is what I wanted to show you. So sensitivity. So the problem in determining sensitivity, so in other words, if we have the question is, we have 100 people with epilepsy, how many will have an abnormality on a single recording? This matters because when a clinician sends a patient to the EEG lab, he's depending upon us to identify an abnormality to correlate with the clinical problem at hand. So this has been studied over the years. So if you do a single recording that, depending upon the study, anywhere between 20 and 55% of patients will have spikes seen on that single recording. Now you can increase the yield by increasing the number or increasing the time of the EEG that you've done to try to elicit these spikes. So if you do a third recording, a fourth recording, a fifth recording, or if you, at the bottom here, if you continue that recording for 1 week, you can see that the yield of those EEGs gradually increases with the time of the recording that you've done. So up to 80%. So here's what you call an operating curve. So this is me taking all those particular studies, lumping them together. And you can see on the bottom axis, there is time in minutes. And on the y-axis, there's IED sensitivity. So those are our number or a proportion of patients with known epilepsy. So if you take all those studies and if you look at that 20, that's a 20-minute standard routine recording, the minimum that is allowed by the ACNS by criterion, you can see that the range of sensitivity is roughly from 50 to 20%, with a single standout with another study showing 10%. So that range of roughly 20 to 50% is kind of low, actually. You can see that once you double the recording time to 40 minutes, the overall number of positive studies slightly increases. And if you go to 60 minutes, it slightly increases. If you go to a one-day ambulatory overnight recording, it increases up to around 70%. And finally, if you observe a patient over a week, it gets to 80%. And it seems that it really never increases beyond 80%. So 20% of patients with known epilepsy will have a normal EEG no matter how long you record from them. Okay, so that's an important limitation to our recordings, but it also means that, hey, we can do a pretty good job, if we choose to do an out, for example, a 40-minute or a 60-minute recording. So why are these 20% of patients with epilepsy without spikes visible on a scalp recording? One of them is dipole direction. We mentioned earlier on in the first painful part of this lecture is that the brain is modeled as a northern hemisphere, a smooth basketball northern hemisphere. The direction of that electrical discharge, or the direction of the neurons in the cortex, may not necessarily point up to where our northern hemisphere electrodes are located. Maybe it's pointing down to the southern hemisphere where we don't have any electrodes. So if the dipole is pointing in a inconvenient direction, we won't pick it up. Furthermore, the volume of the epileptic lesion may be too small. So we saw earlier that a limitation of the scalp recording is you have to have enough cortex firing off at once, what we said was 6 to 10 square centimeters, for us to see it reliably. And if it's below that critical amount, the chance of seeing a spike is reduced. The rate of spikes may not be sufficient. So maybe the patient just generates rare spikes, and we can affect that either by recording during sleep versus wake. So one of the common things that we do is try to capture sleep. Sleep is a spike generating state in many patients. So hanging on there and trying to get the patient to sleep during your routine recording is a valuable clinical addition that you can do to increase the yield of a routine EEG. And finally, there are medications that can affect or dampen the rate of spike recording. And thirdly, interpretation. Interpretation, we can miss it. We're not perfect, even though I can be perfect. Other people can't be perfect, and maybe you'll miss it or mistake it for other things. So I'm going to go back one slide, 2 slides. So for example, on a standard recording, part of learning how to interpret EEG is to both find the spikes and separate them from artifacts or other sharp transients that can be picked up. It's all part of learning EEG. So we can see a couple locations in this recording with sharp transients. So for example, if I circle them here, we can see that there's a true left anterior temporal spike in that upper right circle here. But there are sharp transients that are being generated by just electrode artifacts in this T8, P8, P8O2 derivation. And finally, there's EKG artifacts showing up in the ear electrodes. So again, that's all part of learning EEG is separating the good stuff from the bad stuff. But that can contribute to that 20% missed recording, because no one is perfect. Now, the other, and this is some studies that testify to that imperfection. So for example, if you take a group of children and you record spikes on an EEG, and you wait to see who later develops epilepsy, the location of those spikes seem to have different predictive values. So for example, if some kids have temporal lobe spikes, 90% of those children will subsequently develop epilepsy. If they have frontal spikes, 75% will develop epilepsy. But if they have central spikes coming from the central vertex, only 40%. And perhaps that reason is because it may be easy to mistake the normal findings of sleep on an EEG for spikes. The sharp waves, vertex sharp waves during sleep, are sometimes very spiky looking, and those can be just mistaken. Okay, now specificity of EEG. Specificity means if we find spikes on an EEG on someone who does not have epilepsy, what does that mean for the subsequent chance of this patient developing epilepsy in the future? And I'm going to skip down to the bottom for time. These studies depend upon two important factors. You have to select a group of normal people to study, because we don't want patients with epilepsy in this kind of specificity design. We need normal patients. And we also need some follow-up time so that we can see that if they happen to have an incidental spike, a spike by accident, what does that mean in the future? So the best study that has been done so far is in the Royal Canadian Air Force that did screening examinations for Canadian Tom Cruises, Top Guns. And they did over 13,000 studies over a period of 30 years. And what they found in this kind of supernormal masculine group is that a very small percentage of patients had spikes without epilepsy. And most of those subjects had spikes limited to those gathered during photic stimulation. And they were able to track of the 69 Tom Cruises over the years. They followed them for between 5 and 20 years. And they were able to track 43 of these positive EEGs subjects. And of the 43 they were able to track, they only found one who had developed unequivocal epilepsy. So the point being is that incidental spikes occurring in a otherwise normal subject should not be thought of as a doom and gloom situation. Is that the development of subsequent epilepsy, if you get an incidental spike in a normal subject, isn't something that, for example, should be prophylactically treated. So the rule of thumb is you treat the patient, not the EEG. This is a way of saying that an interictal epileptiform discharge in an epilepsy patient is highly associated and predictive of epilepsy, but in a normal subject is not highly predictive of epilepsy. Treat the patient, not the EEG. All right, we're going to close last couple minutes here just with a review of the different kinds of studies and what they must be suited for. This is just a table that I show my fellows, showing that there's the work-related RVUs, basically the compensation value for an EEG, and the CPT code that matches up. And routine EEGs are those that are typically able to be acquired in the standard outpatient study. And basically, insurance rules require that a routine study is performed before any more extended outpatient monitoring. And we saw from the operating curve is that pretty much 40 minutes, 30 to 40 minutes should be the minimum time for a routine EEG if we have a decent chance of catching spikes. So for example, in our own lab, we've recently changed our protocols so that we are no longer doing 20-minute EEGs. Everyone's getting 40 minutes now. Video monitoring, on the other hand, is when you need to capture in actual behaviors, the gold standard of linking behavior with a possible seizure. And we do these for pre-surgical evaluation and for treating ongoing seizures. And there's a growing attention to insurance carriers for the real-time supervision with a monitoring technologist. And then finally, ambulatory EEG codes are, again, to spell capture when spells are inherent in a specific environment. So if a patient only has spells at home, well, home monitoring is appropriate with an ambulatory EEG. We can use it as a secondary measure if the patient can't be admitted to an epilepsy unit. And you can do it for certain difficult to assess epilepsies, such as absence epilepsy, when the seizures are clinically silent, so you have to use the EEG to actually count them. So in summary, from this diverse set of things we've talked about today, the source of the EEG is the continuous organized electrical potential generated from postsynaptic potentials of large networks of neurons. The sensitivity of the scalp EEG, in other words, if you have 100 people with epilepsy, is limited to 80 of them, no matter how long the recording lasts. And then finally, routine EEG remains sufficient for most clinical needs, but longer recording times for patients in whom we're trying to capture interictal epileptiform discharges, time matters. Video EEG, however, is required when we're trying to link behavior with the actual seizure and requires investment in people to make it work. So this is the end. We can take questions. I didn't leave too much time for questions, so I apologize, but please.
We have a few. Thank you, Dr. Quigg. Okay, our first question is, how can we be sure the skull is acting as a filter as opposed to the fact that the spikes and slow waves are not being propagated to the cortex?
Well, again, the problem with the filter is that any amount of monkey business can be occurring in the cortex, and if it's being filtered out, we won't see it. So, for example, that is one reason why in patients who we're evaluating for epilepsy surgery is that maybe the scalp EEG is not sufficiently localizing, is not sufficiently supplying us with a target. So we have to use intracranial monitoring to overcome the limitations of the scalp EEG.
Okay. This question has to do with polarity. Can you kindly comment on the polarity of different epileptiform discharges in bipolar as well as referential montages?
Okay. Yeah, I didn't go over, all the varieties of epileptiform discharges. So I tend to divide these up into two classes. There are benign epileptiform discharges and interictal epileptiform discharges with clinical significance. Benign epileptiform discharges are a variety of usually sleep-related, sharp-looking things. Example would be rhythmic mid-temporal theta activity of drowsiness or vertex sharp waves of sleep that have no clinical significance in as far as predicting epilepsy. In general, those epileptiform discharges often have a positive potential recorded from the scalp. like positive occipital sharp transients of sleep. Things with negative dipoles tend to be the interictal epileptiform discharges that predict epilepsy. There are exceptions, but negative, bad, positive, good.
Okay. I think this question is, Dr. Quigg, for those patients, after post-craniotomy patients, rather, with EVD, what is the best time to do the EEG for them, as the scalp is now different from the normal patient, and are there any specific protocols or setting that needs to be done with these specific patients?
The point being is that routine ICU EEG monitoring, different centers will designate different protocols. So for example, routine EEG monitoring in the ICU for someone who's had a ventricular peritoneal shunt placement acutely isn't usually needed. So, the timing of such, I think, is largely clinically required. So if that same person with the VP shunt was having problems and difficulty in fluctuating consciousness or impaired consciousness, not waking up, then the EEG is needed relatively immediately to determine if like ongoing non-convulsive status is occurring. So I think it depends upon the clinical situation. Certainly electrode on the scalp can be placed with perhaps a notation by the tech that the electrodes are being shifted around a little bit to accommodate any hardware that's on the skull.
Okay, I think this will have the list with one question from our colleague Clarissa. I think it's a two-part question, so I think this will be our last one. If we did not answer your question, please send us an email and we will make sure you get a response. So Clarissa is asking, can we increase the chance to see IEDs on the first EEG if we ask the patient to be sleep deprived? I think you kind of touched on that, but maybe you can elaborate.
Yeah, I didn't explicitly mention sleep deprivation.
Right.
Sleep deprivation and sleep are independent but related spike-provoking activation procedures that can and should be done. So for example, sleep itself is a state that promotes production of spikes in many of the epilepsies. So having a patient sleep during the EEG is great. Sleep deprivation is good for two things. One is that, I'll just summarize by saying the overall hormonal stress reaction in sleep deprivation is helpful in generating spikes, but it is also helpful because it will help promote the occurrence of sleep. So it has kind of a double dipping, if you will, in its effect. So I'm a fan of sleep deprivation for generation of spikes.
Okay, and quickly, the second part of Clarissa's question is, could continuous monitoring in an epilepsy monitoring unit where patients are observed for 24 hours enhance the likelihood of detecting EEG abnormalities?
The answer is yes, unequivocally yes. The longer the EEG, the more likely it is that an interictal abnormality will be demonstrated. But you saw that there is a limit. There's kind of this 80% limit, and no matter how long you do it, you're not going to get any better. So the problem is that if you're admitting someone to do 24-hour EEG just for the sake of getting interictal epileptiform activity, maybe that isn't necessarily clinically indicated. By that time, if you're seriously considering admitting someone to get interictal spikes to support your diagnosis of epilepsy, maybe you should be considering a trial of anticonvulsant medications beforehand.
Well, with that, so on behalf of Natus and our Neurotraining Academy, it's been a pleasure having you join us. And again, I would like to thank our speaker, Dr. Mark Quigg, and this will conclude our presentation. Thanks everyone for your participation. Enjoy the rest of your day or evening, and we will certainly look forward to seeing you next time.